It's my honor to introduce our speaker today. It's Dr. Stephanie Kinney. She's our fellow, one of our fellows this year in transfusion medicine. She's originally from Plymouth, Indiana, did her undergraduate work at Butler University. She majored in religion and minored in chemistry. She went to medical school at Indiana University, School of Medicine, did her pathology residency there as well. And we were fortunate enough to have her come to us for her fellowship. She's already got a job lined up, so her next stop is Cincinnati Children's Hospital, where she'll be Associate Medical Director of the clinical laboratories with focus and oversight of the blood bank. And Stephanie is going to talk on NK cell infusion reactions.
Thank you. Good morning. Can everyone hear me okay? Yes. Perfect. So I just want to ask, first of all, how many people have heard about or know a little bit about using NK cells, natural killer cells, for cancer therapy? Raise your hand for me. Oh, good. So more than what I expected. So wonderful. So hopefully I won't lose you too much and keep you right on the track. I have no disclosures. So my objectives for you this morning are I'll review NK cell biology. We'll talk about the NK cells used for cancer therapy. I'll talk about past clinical trials. Then I will also explain how we process these and make the cell product in the cellular therapy lab. And then I'll talk about a little bit about my project that I've been working on the past several months, NK cell infusion reactions or toxicities. And then I'll briefly spend a little bit of time, just one slide, about where to go in the future with NK cell therapies. So we'll start at the beginning, best place to start. Natural killer cells were discovered in 1975, and they were named for their natural tumor-killing capacity. They can lyse a cell without prior sensitization. When you look under the microscope, they're large granular lymphocytes, which are the first two pictures on the top here, just to give you a frame of reference. They're known to be CD56 positive CD3. That's how we identify them based on their markers. And they comprise about 10 to 15% of peripheral blood lymphocytes. So this diagram is just showing you where NK cells come from. We have our pluripotent stem cell up here dividing into our granulocyte, monocyte, or myeloid lineage on your left, and then the lymphocyte lineage on the right, and natural killer cells come from this lineage here. So natural killer cells have actually a whole different range of functions. They play a big role in initiating the immune response. They interact with dendritic cells, and they can each activate each other. And then natural killer cell-induced dendritic cell activation can also result in the initiation of the adaptive immune response by helping dendritic cells to present antigens to T cells. So this is our first area. Next, naturally, activated natural killer cells can go on to destroy malignant tissues. Specifically, they're well known to destroy AML cells. Next, there's some data out there that shows that there's a subpopulation of natural killer cells called NK22 cells. They can produce IL-22, and they can interact with lymph node stroma and can mediate mucosal immunity. In the setting of allogenic stem cell transplant, NK cells can eradicate recipient stem cells, and they can help to facilitate allogenic stem cell engraftment. Down here, point 5, a unique population of uterine natural killer cells are responsible for maintaining pregnancy. And finally, they help to surveil and respond to infectious organisms like HIV, CMV, and hepatitis C. Natural killer cells can also be divided into two different subsets. CD56 dim, where they have less CD56 on the surface. These are the most potent natural cytotoxic NK cells. They have more FC receptors, or CD16, present, which help with antibody-dependent cellular cytotoxicity. I'll also just point out here that natural killer cells, both subsets, possess an IL-2/15 receptor, and these cytokines are really important in activating NK cells, and you'll see in the future for subsequent trials how we've kind of harnessed this. And then there's a CD56 bright subunit. These are more proliferative, less cytotoxic, but they can produce large amounts of interferon gamma or cytokines. So NK cells work because they have receptors on their surface that help to mediate activating and inhibitory signals. Many are MHC class 1 specific or HLA class 1 specific. The engagement of this class 1 on other cells results in the reduction of NK cell function. So this is an inhibitory receptor. So if the natural killer cell recognizes an HLA class 1 receptor, it inhibits the NK cell from acting, and it will not destroy the target cell. So this is good, so our NK cells don't run around uninhibited in our body, destroying all of our cells. But, for example, when a cell is infected with a virus, it can lose this MHC or HLA class 1 ligand, and in that case, it's a perfect example where this inhibitory receptor is not activated, and the NK cell can carry out its function and destroy the cell properly. So NK cells have actually multiple weapons of destruction. The first is the KIR ligand, or killer immunoglobulin-like receptor, which recognizes HLA class 1, mostly HLA C, which is interesting. These are inhibitory and activating KIRs. Then there's a C-type lectin receptor, mostly activating, and a natural cytotoxicity receptor, which is also activating. You'll hear me talking more about the first one as far as in clinical trials and how we've used this to help with harnessing its power. So I'll attempt to go over NK cells in clinical trials. There are a lot, and I could spend a couple hours actually just talking about all of these. So I'll try to summarize it and how it's relevant and interesting to us here. There's a couple different ways that we started out using NK cells. The first one we could try to use when a patient gets a transplant or an allogenic stem cell transplant from someone else. There's natural killer cells naturally in that transplant, so we can try to harness that power and try to help those natural killer cells carry out their function even more, and that's one way to do it. So this was in 2002. Ruggieri and colleagues, they demonstrated superior disease-free survival in AML patients who received bone marrow grafts from HLA haploidentical donors. So these are donors who are 50% HLA matched. And these donors expressed KIR receptors, which bind to the class 1 molecules, like I said, that were absent in the host. So this is a KIR ligand mismatch in the graft versus host direction. So the donor had KIR ligands that the recipient did not, and so hopefully get those natural killer cells to work in the direction we like. They found very interesting results and quite shocking, actually. So let's see. This group over here on the left, they did not have KIR ligand mismatch, and the group on the right did have KIR ligand mismatch. So they looked at patients with ALL and AML, and these are the numbers. This is a single institution study. In transplant outcomes, rejection, the patients without KIR ligand had a 15.5% rate of rejection, and in the KIR ligand mismatch group, 0%. Acute GVHD, again, pretty shocking in that the Kerr-ligand mismatch had 0% rate of acute GVHD. And the probability of relapse at 5 years in the non-mismatched, 90% and 75% for ALL and AML. In the Kerr-ligand mismatch, 85% for ALL, but 0% for AML. So this was pretty shocking, actually, with these results. The probability of survival for the Kerr-ligand mismatch patients was 65% at 5 years and 5% for those without. And like I pointed out, this was also an important paper that showed that the Kerr-ligand mismatch had no effect on ALL patients. So naturally, other places tried to reproduce these results since they were very shocking and revealed a lot. So this was probably the largest study. It's a multi-institutional national look. They looked at the NMDPs, so the National Marrow and Donor Program in the United States here, their registries, the European BMT registry, and the Dutch registry, and they were able to get 1,571 unrelated donor transplants for myeloid malignancies to look at and see if this mismatch also had the same effect. So these were the 4 different groups that they looked at. The first was HLA matched, and the rest had some kind of mismatch, whether it was this is the same GVH Kerr-ligand mismatched that the last paper had looked at, and a couple different other mismatches. They compared these groups using Cox regression models, and they found that treatment-related mortality, treatment failure, and overall mortality were the lowest after the matched transplantations, so this one. In patients who received grafts from donors mismatched at the Kerr-ligand, they had similar rates of treatment-related mortality, treatment failure, and overall mortality, and there were no differences in leukemia recurrence between the 4 groups. So this was in direct opposition to what the first group found, but there are several differences to keep in mind with this. There's a difference in sample size, which is large. Transplantation techniques were probably different among these groups. And the methods to determine Kerr-ligand incompatibility could also play an effect. Something else I think that is really important is that the first group looked at haploidentical stem cell transplants, and these are usually T-cell, and I think all of those in that case were T-cell depleted to prevent graft versus host disease. This study looked at unrelated donor stem cell transplant, and they said that 80% received unmanipulated grafts, and if they were T-cell depleted, it was only partial at best. So T-cells are playing some kind of a role with the natural killer cells and their ability as far as the Kerr-ligand mismatch. So here at the U, we first tested, so now that was kind of harnessing the power of natural killer cells that are coming along with a transplant. And so we wanted to try to harness the power of, if patients get their own natural killer cells back in an autologous transplant, can we somehow help to manipulate in vivo in the patient those natural killer cells to make them more active? So here at the U, we first tested the use of low-dose IL-2, one of the cytokines to help activate NK cells. IL-2 was used daily to expand NK cells after autologous transplant in patients with non-Hodgkin's lymphoma and breast cancer. So natural killer cells were also being used not only for the myeloid malignancies, but for solid tumors as well, to see if they could have any kind of effect. Later on, we then activated autologous NK cells outside of the patient, so ex vivo, with IL-2 for 24 hours to try to activate them more, and then infused them in the patients and administered daily sub-Q IL-2. I'm not going to go into the full details of this paper. It showed limited efficacy, but it revealed important findings that IL-2 could be administered safely to patients, that IL-2 could induce also circulating cytotoxic lymphocytes with a disproportionate increase in NK cells, that recipient lymphocytes can compete for cytokines in space, mainly talking about those T cells, and autologous NK cells were unlikely to kill tumors because of inhibitory signals delivered by the self-MHC. So interesting that we proceeded down this path as well. But we more importantly, wanted to see if we can get IL-2 safely into patients, because for our next big thing that we did here was we did initial studies testing allogenic NK cells and in a non-transplant setting. So now we're taking NK cells from a donor and transplanting them or giving them back to a recipient. So we use family-related HLA haploidentical donors. The apheresis product were CD3 depleted, so we removed the T cells from the NK cell product, and they were activated in the cell therapy lab overnight with 1,000 IU of IL-2 for 24 hours. The patients received, there were two different arms. They received either low-dose fludarabine for 5 days or high-dose cyclophosphamide for 2 days, followed by the same dose of fludarabine. And this is known as the high Cy-Flu arm. And those were given before the NK cell infusion. Then they got that. And then IL-2 was administered daily for 14 days subcutaneously. So shown here on the left, this is the average percent of donor peripheral blood mononuclear cell engraftment for each arm. There was in vivo expansion of donor cells by day 7 in the AML cohort, which is the top group here. And they were the group that received the high Cy-Flu dose, but not in the renal cell carcinoma group who received the low dose, just fludarabine dose. On the right, over here, this is from one patient, and these were peripheral blood mononuclear cells collected 14 days after the NK cell infusion. Figure A here shows that 92% of all circulating cells were CD56 positive, CD3 negative NK cells. And figure B over here shows that fresh day 14 samples were tested with a 4-hour chromium release assay to demonstrate cytotoxicity. And it showed that these NK cells were actually effective. They had high percent specific lysis. Case 562 is a NK cell sensitive cell line, and the Raji cell line is an NK cell resistant cell line. So kind of to use as more of a control. But they were active NK cells that were infused. So we noticed from this study that only patients who received infusions after the more intensive high Cy-Flu resulted in a marked rise in endogenous IL-15, meaning that NK cells were actively producing cytokines. They had expansion of their donor NK cells, and it also showed induction of complete hematologic remission in 5 out of 19 poor prognosis patients with AML. So next, we used IL-2 to give to patients to try to expand the NK cells once we gave it back to them. But IL-2 has been known to also expand T regulatory cells or suppressive T cells. These Tregs have a high affinity IL-2 receptor, and so they can directly and indirectly suppress NK cell activity. So we tried something a little bit different. In subsequent trials, in this one we treated 57 refractory AML patients with high Cy-Flu and allo-NK cells, just like the first one. But 15 patients received an IL-2, a diphtheria toxin, and this is a recombinant cytotoxic fusion protein, which is composed of amino acid sequences for diphtheria toxin, and it's a truncated amino acid sequence for IL-2. So this was thought to help deplete Tregs and improve donor NK cell persistence and expansion. In 42 patients who received regular IL-2, they showed donor NK cell expansion at day 14 detected in 10%. But in the 15 patients receiving the IL-2 DT, donor NK cell expansion was detected in 27%. So we had a slight increase and a little bit more success. And it was the IL-2 DT was associated with improved complete remission rates at day 28, at 53% versus 21%, and a disease-free survival at 6 months, 33% versus 5%. So an improvement. But then, as things evolve, IL-2 and IL-15 signal through common gamma chains and beta chain receptors. But unlike IL-2, IL-15 does not stimulate T regulatory cells. And so we thought that IL-15 should be better for in vivo NK cell expansion and persistence. And so we tested this in the next clinical trials using National Cancer Institute's monomeric recombinant IL-15. Okay, so we're going to switch gears a little bit. And I'm going to talk about how we process these cells in our cellular therapy lab. So the collection process, we have our haplo allogeneic donor who goes to our donor infusion center to undergo a 5-hour apheresis procedure collection. Once they're done, the product gets sent over to the cellular therapies lab. And there we could do our cell selection process using the Kinney Max or Miltini device. This device you add in, incubate with mouse anti-human CD3 or CD19 ferromagnetic particle. So you add in the markers and the particle that of the cells that you're looking to remove. So we have gone through an evolution, and I'll talk about this process in the next couple slides as far as which cells we remove from the product. We originally started out with CD3, but we currently now remove CD3 and CD19, so T cells and B cells. So then these particles, the magnetic particles, will bind to those markers on the cells, and then the device has a magnet that selects and pulls out those cells, and you're left with your remaining cells, which in this case, if you're selecting for 319, you're left with NK cells and monocytes. Then they're placed in a Teflon bag, and they're incubated overnight. Ex vivo is a cell medium solution. They're incubated with either IL-2 or IL-15 and AB human serum. Next day, when they're ready to go, we wash them a couple times and then resuspend them in the human serum albumin. And then they have to undergo several lot release testing. We look to see how many NK cells we have, how many T cells and B cells are left. We look at viability, endotoxin, and gram stain. So in a CD3 depleted NK cell product, this is directly after apheresis procedure, what you have in the bag. After we do our cell selection for CD3, this is what you're left with: monocytes, B cells, and NK cells. This is just a little interesting side note. One of the reasons why we deplete for CD3, we've done that up front, is to try to prevent transfusion-associated graft versus host disease. And this is when a recipient or patient is exposed to foreign T cells, when they're especially in an immunocompromised state, but could also happen in immunocompetent patients who are susceptible. It's nearly always fatal, and there's no current treatment other than supportive care. To prevent this from the blood bank side as well, we irradiate our products if possible to try to prevent it. We don't want to irradiate our natural killer cell product. That would kill our NK cells. And so in the blood bank, we also do leukoreduction to reduce the incidence, and why we remove the CD3 from our NK cells. The exact threshold for the T cell content that causes transfusion-associated graft disease is not exactly known, and even more so because we've administered over 100 NK products that are T cell depleted, but they still have T cell loads that are 25-fold greater than the FDA guidelines for red cells and platelet products. And we have had no cases of transfusion-associated graft versus host disease. And this is a really high-risk population. We're giving them fresh cells. They're related, haploidentical donors, and they're receiving fludarabine, which is like our no-no drug, and it's on our list to irradiate if we ever find it in patients for blood products. And no cases of transfusion-associated graft versus host disease. So this points out that there's some other mechanism with TAGVHD in pathophysiology that's also underlying in these patients. So just an interesting side note for the blood bank community too. So then next we thought, well, maybe we could just get a more pure NK cell product. If we selected out, we did our CD3 depletion first, and then maybe we could select for just NK cells, so select for CD56. This should be the most ideal product to give to a patient. We're getting rid of any cells that we don't want, and we have just all the cells that we want. So it seemed optimal from not only patient side at safety, but also regulatory. But when we did this in a trial, the NK cell recovery and thus the dose, they were low with the CD56 enrichment. And 12 patients were actually treated with this product, and none achieved clinical remission. So we returned back to the CD3 depleted product to confirm our earlier results. And then something happened. Actually, a couple things happened. This is just one example of a case that led us to alter our manufacturing of the products. So this was a 56-year-old woman who had stage 4 ovarian cancer. She was treated with several rounds of chemotherapy over 2 years with progressive disease. So she was sent here for follow-up and workup for a potential treatment of NK cells. 7 days after her NK cell infusion, her hemoglobin was noticed to drop from 9.7 to 7.5. She didn't have any evidence of bleeding. Before her NK cell infusion, she was blood type A positive, and she had a negative antibody screen. They did hemolysis labs and found that she did have evidence of hemolysis. She had elevated bilirubin and LDH, decreased haptoglobin, and her DAT was positive. We did an LUIT then, where we pull off the antibody from those red cells with a positive DAT, and we try to look for what specificity this antibody has. And we found anti-A, which is really interesting. We also found anti-A on the patient's back type, but she's A positive. So then we go looking for sources of where could she have gotten this anti-A from. We look to see if they got plasma from ABO-incompatible products like platelets. We looked to see if they got IVIG, and she hadn't. Any ideas of where she could have gotten exogenous anti-A? No ideas? So she received an NK cell infusion from an O positive donor. So this donor has B cells present in that product. This was just the CD3 depleted product now that we're talking about. So left in the bag are NK cells, monocytes, and B cells. This donor's B cells are producing anti-A and anti-B appropriately. And this is where she got the anti-A from. So this is called, we have a term for this, passenger lymphocyte syndrome. It's immune-mediated lysis of the red cells due to differentiated mature B cells that can either follow along with solid organ transplant or stem cell transplant. Patients in the immunocompromised state and pancytopenia, they're not able to mount a response to attack those donor lymphocytes that come along with the transplant. Hemolysis usually stops as soon as the patient's red cells disappear or they're all lysed. And they're usually transfused with antigen-negative cells, and there's only a certain population of lymphocytes that come along with the transplant, and they don't engraft and they cease to proliferate. So you just have to bide your time till you can get through the process, and that's what we did. We transfused her with O RBCs, and she made it through. At discharge, her DAT was negative, and she had a negative LUIT. She was typing as an A with a little bit of O, because we gave her a bunch of O red cells, and weak anti-A was detected. By 2 months, she had clear progression of her ovarian cancer, and by 10 months, she unfortunately passed away. But this was an important case along with, we actually had 2 cases of passenger lymphocyte syndrome and 1 case of EBV that may have come from NK product, or it might have been a reactivation in the recipient. But this led to modifying our manufacturing to where we now currently and will for the future T-cell deplete and B-cell deplete all the NK cell products. So now I'll talk about a little bit of my project that I've been working on for the last several months. In talking with one of the clinical research nurses who follows along all these products and witnesses and documents for each of these NK cell infusions, she noticed a few things and brought it to our attention in the cell therapies lab while these patients were getting these infusions. Why do some of them have more severe reactions than others? Could we maybe predict who will have a severe reaction in the hopes of maybe preventing it? And why are some patients from the more recent clinical trials, they're starting to have these severe headaches with the NK cell infusion? And so could this be related to our product or a whole host of a bunch of different things? So these are a bunch of the variables that we're looking at. Could it be related to the protocol? So patients in the past, most of these patients have received the high-Cy flu priming chemotherapy, but there's a few differences and tweaks among that. So could protocol differ? Patient's diagnosis, so we've used NK cells for several different diseases. Could that matter? What about the patient's and or donors' age, sex, or blood type? What about if the product was incubated in IL-2 or IL-15? NK dose, percent viability of the product? Maybe the time between when the product was ready and the infusion start time, if that was longer, did the NK cells have longer to activate and potentially increase cytokines? What about the monocyte content? Because now that we're doing CD3, CD19 depletion, what's left in that bag is NK cells and monocytes. What about the rate of infusion? If we go faster, do more people have more reactions? Maybe the volume infused matters. Did the people that have reactions have NK cell expansion at day 14, and did they have increased function? Does that mean if they had a reaction that the NK cells were actually working? And then maybe looking at also to help answer that question, what about the patient's clinical status of their disease if they had a reaction? So this is a big task, a lot to look at here. And we're in the beginning stages of looking at several of these, so I tried to put together a few things for you for this. So we defined reaction as any symptom from the time of NK cell infusion up to 4 hours post-infusion. A severe reaction was labeled as grade 3 severity or higher of any symptom, and the symptoms are graded on a common terminology criteria for adverse events, or the CT-CAE form. So here's an example of the form, and I don't expect you to be able to read it, but this just lists all of the symptoms potentially possible with an option for other as well. And then the different grades from grade 0 up to grade 4 in severity of the symptom. So the data that we have that's complete and reliable as far as infusion reaction recording, it spans 9 different clinical protocols from 2008 to 2016. Although we've been doing NK cell infusions since 2001, some of the data of the actual infusion reactions is not very reliable, as reliable as these date ranges. So there was a total of 127 NK cell infusions in this span of time. The different diagnoses during this time that we treated were breast cancer, ovarian cancer, NHL, and AML. Total patients with any reaction is 94%, so usually they'll have some kind of symptom. Total with a severe reaction, though, was only 29%. I went back to try to quickly find what I could from the data that I'd gotten from the clinical side about patient disease status, and I only have right now 18 completely documented from these patients with severe reactions. And out of those that were well documented, 8 out of these with a severe reaction had a partial or complete remission of their disease. So I'm not 100% sure what to make of this yet. It will need to be fleshed out more. This is a list of the different types of reactions. So grade on the left, 1 to 4. The symptom is listed at the top, so chills, fever, edema, dyspnea, hypoxia, bronchospasm, hypertension, hypotension, an injection site reaction, pneumonitis, or a rash. As you can see, most of the symptoms are chills, which is the first one here, followed by hypertension and fever. Some of the severe symptoms include the respiratory ones with dyspnea and hypoxia and bronchospasm, and some hypertension. One grade 4 was hypotension. So this is any symptom is the dark blue, severe symptom, light blue, and then greenish is if they had a headache. These were kind of the endpoints we were preliminarily looking at based off the protocol number. These 2 protocols are the IL-15 protocol. The rest were used IL-2. So trying to look to see if there's any difference between using IL-2 versus IL-15. I'm pretty much discounting any symptom because you can have it with pretty much everyone has at least one. So I'm focusing on the severe and or headache to see if I can find any differences. This is an interesting group here in that they seem to have the highest rate of severe symptoms. And I'm going to have to flesh this out a little bit to see exactly what that entails some more. We looked at infusion rate. I was sure, almost could have bet my money it was going to be on infusion rate, but we were wrong. We looked at infusion rate mils per minute, not statistically significant among these outcomes. And then we broke it down mils per minute per patient weight to see if that mattered. Not so much, maybe reaching a little bit statistically, but not. And then we looked to see if incubation in IL-2 versus IL-15, not much of a difference. What about looking at CD3 versus CD319 depletion? Somewhat increase in our CD319 depletion. And I think that maybe has to do with something I'll show you in just a little bit. And this is our monocyte percent. So a calculated monocyte percent in the product, reaching close to statistically significant, and if we break it down to dose, where we're using the patient's weight in there, we reach statistically significant in the severe group outcome, although we do have a few outliers up here. These 2 patients actually had a headache, and they were a grade 2 headache, so whether or not that potentially matters, I'm not sure. But it looks like there maybe is something to do with our monocytes in the product. We knew about this back in 1992. We knew about the role of monocytes in the expansion of NK cells. In experiments in Dr. Miller's lab here, they showed that the cell culture system showed that the stimulatory effects of autologous peripheral blood MNCs on activated NK proliferation resides in the CD14 monocyte fraction and not on the T cell or B cell fractions. When they co-cultured the purified NKs and autologous monocytes in the same compartment, so this allowed for cell-to-cell contact, it resulted in significantly greater expansion of the activated NK cell population. And this was not observed when they were separated. So monocytes play some role in activating our NK cell product. So you might think, well, let's just get rid of the monocytes. They're causing all the problem. But I'll remind you that we tried that and they weren't effective at all. Interestingly, I went back and looked at these 12 patients to see if they had any infusion reactions, and only 2 of them had mild chills. So very interesting. So what about these headaches? When I talked with the clinical research nurse, Dixie, she was describing what these patients felt. That when it happened, it was sudden, quick. They gave her this look. It was an intense pain, like forehead behind the eyes, like hot pokers. And these people were in such pain that a couple of them have rolled out of the bed with this intense headache. She said that after talking to several of them, most who developed severe headache reported some history of migraines in the past. I tried to confirm this by looking back at some of the patient's chart of past medical history, and I couldn't confirm it for my data, but this was anecdotal of what she observed. To me, recalling back my clinical medical knowledge, this sounded a lot like a cluster headache symptom when you learn about the most severe headache out there. This is one that rings in your head, only this didn't happen in a cluster. This was one time. But here's some of the symptoms of a cluster headache. It happens without warning, quickly, excruciating pain around the eyes. It could be on one side of the face, or headache around the forehead. They're restless. They can have physical symptoms, so they could get, and I didn't ask her this, which will be my next question about these patients, did they have tearing or redness of the face? And usually those are the cluster headache. They cannot sit still, and they pace back and forth or rock. Sounded pretty similar to me. So I went looking in the literature, is there anything connected potentially at all? There's actually a few couple papers out there that talk about patients with a cluster headache had significantly increased soluble IL-2 receptors. And so they're thinking part of the pathophysiology, although it's not completely understood with cluster headaches, that it's inflammatory mediated somehow. And so they're looking for causes, and they found that they had high soluble IL-2 receptors, and that people with cluster headaches had increased relative IL-2 gene expression levels between headache attacks during the cluster headache period. So potentially if these people have a history of migraines, perhaps they're primed somehow to be more sensitive to specific products. So next steps, to explore the additional variables I didn't have time to get to, and break down the severe reaction based on symptoms. Some symptoms might not matter as much as others as far as what we consider a severe reaction, potentially maybe skewing the data a bit. So I want to break it down even farther. So last slide is just to talk a little bit about the future directions for NK cells. So we've already seen kind of this side on the left somewhat is kind of where we've been working. We tried autologous transfer, but potentially there's a way we could manipulate the cells even farther for autologous. We've done an allo donor, which is what most of those clinical trials were that I've talked about. Alternative sources for NK cells, if someone doesn't have a donor, could include NK cell lines, or also induced pluripotent stem cells. And then these NK cells could potentially be further modified with chimeric antigen receptors for patient-specific tumors. So kind of like they do the CAR T cells, but we could potentially do a CAR NK cell. Then if we come up here in the hematopoietic stem cell transplant, we know that NK cells are transferred with the graft. So could we maybe help to modify these even more? And potentials include that if the patient reactivates CMV, this can create a memory-like NK cell, and there's research out there going on right now. Could we harness this effect potentially with maybe a CMV vaccine strategy to help make these memory NK cells? They've looked at patients that have had CMV reactivation after a transplant, and they actually have better outcomes than patients that don't reactivate CMV. And then could we manipulate the NK cells potentially even more once inside the patient? So these could include using monoclonal antibodies to block the inhibitory KIR receptors. And so if and a lot of this is in the solid tumors. They have problems because the tumors have an environment to help, and/or they might even have a HLA class 1 that would inhibit the NK cells from functioning. So if we block this from recognizing MHC class 1, could we potentially help our NK cells activate even more? And then CD16 down here, could we stimulate those using a bi- or trispecific antibody, so BIKEs or TRIKEs? These are bispecific killer engagers, and these combine fragments of antigen binding sites from 2 or 3 different antibodies. So we could have a single chain FV against CD16 and maybe a single chain against tumor-specific antigen like CD33, which is present on some myeloid malignancies, and help bring those 2 cells closer together, the NK cell and the tumor cell, to activate. And then once NK cells are activated, they actually downregulate their CD16 receptor, and that's done with the help of ADAM17 metalloproteinase. And so could we maybe inhibit this activity from happening to keep CD16 on there longer? And then could we also find maybe ways to help suppress or get rid of T regulatory cells, which we know and have seen suppress NK cell activity? So lots of areas to go and to keep moving forward, which I think we will. So these are my references, and I'll take any questions now if you guys have. Yes?
Stephanie, that was a very interesting presentation. Thank you so much.
Yes.
You mentioned this briefly, but could you expand on why NK cells seem to be much less effective in solid tumors than in hematopoietic cell tumors, particularly the AML?
Yeah. So there was some thoughts that and evidence that they weren't very effective. We've done breast cancer, ovarian cancer, renal cell, and there's literature out there showing that the solid tumor microenvironment is inhibitory and can suppress the patient's immune function, potentially suppressing NK cells.
Okay.
I'm not sure exactly how that happens, but also could the tumor cells, if they still have an MHC class 1 or an HLA class 1 antigen present on them, then that will not activate NK cells. They'll see that and they won't be active to kill the tumor cell. So they're thinking those 2 things are inhibiting NK cells from being very effective in the solid tumors. So they're trying to manipulate ways in the future to decrease those activities. Yes?
In the beginning you talked about AML and high success rate. Was that a very heterogeneous population of AML, or was it highly enriched with one type?
I'm not sure. I think most, and the ones that we've looked at here, are AML patients that have relapsed or are not responsive to therapy anymore. So poor survival AML.
I mean subtype of AML.
No, I don't know the answer to that. Yes?
So when you expand these NK cells, do you get the NK cells from cryopreserved blood units? Or are they all fresh?
No, they're all fresh, and that's potentially maybe one of the ways in the future if we could somehow harness cryopreservation of NK cells, but right now they wouldn't be able to tolerate the freeze and thaw process. But if somehow we can figure out how to help them last through that, that would be a potential tap and source of NK cells for the future. But right now these are all fresh. Great. Thank you.